Okay, so welcome everybody. Good to see you on the call. We will get started as the tradition of this. So we're again some really great frontline operational topics to be hearing about from colleagues across the organisation. You can see the agenda there. So as usual, we will go through the presentations. So if you want to save your questions up till the end, and then we'll get a chance to get into some of the questions. So I'm going to start off looking forward very much to the next instalment from Donna and Josh around the paediatric cardiac surgery. Remember the last one really well, so let's look forward to that. Over to you.
Brilliant, thank you very much. So hello everyone, my name is Josh. I'm a business manager for the Leeds Children's Hospital, and I'm a co-process owner of the Paediatric Cardiac PICU, RPIW. Today we're at our 90-day report out, so yeah, I'll get started. So how did we get here? The National Cardiac Standards state that 500 operations need to take place per financial year to allow for our competencies to be kept up to date. Prior to COVID-19 in 2019-20, Leeds achieved this for the first time, and we were expected to carry on doing so. But obviously with COVID-19, it led to many challenges, such as loss of staff, deployment of staff, reduction in elective cases listed as well. And this led to an increase in the waiting list, which has been compounded by the increase of staff vacancy as well, which is especially in our PICU and theatres. It was therefore recognised that we had an increasing problem with kind of no identified solution, and therefore we asked the KPO team to become involved in order to try and identify where the issues are, how these could be improved, and could we find new ways of working together. So our aims, we had two aims prior to the RPIW, and that was the first one to reduce cancellations due to a lack of PICU bed, and that was by 50% within 6 months. And the second was for 80% of paediatric cardiac cases to have no late starts. So for our RPIW, we had key stakeholders attend the week to work together, collaborating and leading on several different work streams, which we've been able to continue and develop during the last 90 days. So the first one was the prioritisation protocol, which was put in place to help empower decision making from and within our nursing teams, and this was to allow robust decision making first thing in the morning at 7 a.m. So we've not actually been in a position to utilise the protocol as we'd initially intended, and that's purely due to the fact that our PICU has been in an improved position. So the feedback on the developed tool for nurses is really positive, and it is something that we're going to be able to execute later this year. But the really great thing is that we're able to create a foundation for our nursing teams to lead with and feel confident when they need to make decisions. So the fast track and enhanced recovery is still a work in progress. We've not been able to isolate our fast track to a particular day just yet, but we do have the opportunity to highlight patients that are suitable for enhanced recovery. So our acute position is in a much improved position, with currently all of our acute patients now having a date for surgery in the next couple of weeks. And that's allowing us now to take to list most of our overdue priority 3 and 4 patients and start tackling the waiting list overall. So our aim is to have a secure day every week ready for winter, and we're going to be in a really good position to execute this. The morning huddle, which is all about streamlining the communication from L51, with a quick meeting from all of our teams to coordinate the decision, get rid of unnecessary or duplicated communication, and ultimately the aim of reducing any late starts for our patients. So with the previous report out, Donna said that we'd observed certain days and the certain teams weren't joining, but between the 60 and 90 days there'd been a significant improvement, and this was also the same for the communication that we issued with a change on PPM, and that's something that we introduced in the RPIW, and that was one small change that signalled if a patient was ready to go to theatres visibly on PPM, and that's been received so positively throughout our teams, and we plan to continue with this. So both the staff forum and the people link are there to build relationships and continue the collaborative working. The staff forum has evolved, and we do have our first Leeds Children's Hospital engagement forum taking place on the 17th of July. What we initially wanted was something more centralised to the teams working in the cardiac patient's journey to theatre. So we'll be shortly introducing bi-weekly LIM huddles into PICU, where we can start to plan our post-report out plans and continue to improve the service for both our patients and our staff. This was something that we really wanted to focus on, as the communication between our teams was still a priority, and we knew there was room for improvement. The People link, however, has been an incredibly successful, and essentially a 15-minute snapshot of our PICU capacity, the waiting times, any patient cancellations, and the scheduling for the following week. It's taken place and shared on the PICU, and very recently Teams to even capture even more people working across the site. The engagement has been absolutely brilliant, and we've been able to share with all of our teams a bit of a success story and improvement in a really quick and nice environment. So we're planning to involve the celebration of this with a People Link board, which our KPO team are going to support with, and the People Link is going to continue weekly post the 90 days. So this is a really simple but quite beautiful graph, just telling the success story of our reductions in quick care bed cancellations. So there's still a lot of work to do in preparation for the winter bed pressures, but we have a much better foundation to move forward with, and we also know what we want and ultimately need to put our energy into next. So looking at the target progress board, you can see we've made improvements across all objectives. So our lead time has improved with a 65% change from the baseline, with both quality defects throughout observations being recorded with little to zero late starts, and that's no incorrect cancellation reasons as well. We can also see that our patient satisfaction has improved, with progress that we can still make to make sure that we're achieving 100%. But the final target, which focuses on staff satisfaction, which started at 21% for our workforce feeling valued, it has made an increase to 33%, which is really great to see. But we know that there's still a lot of work that we need to put into the team to improve morale, retention and collaboration. And that's what we're going to be focusing post 90 days. And with just some small changes to our processes currently, but with also implementing new ideas that we weren't able to execute in our RPIW, we feel really confident that we're going to be able to increase the overall staff satisfaction even further, and we're really excited and on board to do so. Thank you. That's everything from me.
Fantastic. Thank you very much, Josh. Lots to go up there, and really great work. And you can see lots of rounds of applause popping up on the screen. So really good. One or two things I'm sure people will want to come back with questions, but really heartening. So I'm going to, as I said at the beginning, I'm going to go through, as we normally do, the presentations, and then we'll take questions at the end. So if I can move on to Nancy, please. Welcome to give us the update around patient harms through delirium education.
So good afternoon, my name's Nancy. I'm a clinical educator for AMS. My base wards are J42 to J47. I also act as a clinical educator lead for pressure ulcer prevention and nutrition. My improvement project is around reducing patient harms through delirium education. Delirium is a common serious clinical syndrome characterised by sudden onset and fluctuating new confusion. It can take the form of hyperdelirium, causing agitation, disorientation and hallucinations, or hypodelirium, where the patient becomes withdrawn, sleepy and unresponsive, or a mixture of both. My quality improvement project came about on the back of recognition that patients are suffering numerous harms where sudden onset confusion or unexpected non-concordance were identified during completion of the Stop the Line documentation. Stop the Line is a method of incident investigation that takes place at the time of the incident, ideally within 8 hours. Its goal is to identify the key factors that led to the incident occurring in the first instance and to use that knowledge to prevent further incidents. A number of RCA panels, both for pressure ulcers and falls, identified that delirium may have been the cause of the sudden, new or intermittent confusion, and the AMS nurses were not identifying or acting on the diagnosis of delirium in order to prevent or reduce those harms. I undertook a data trawl to identify the prevalence of this within AMS, identifying that 8 pressure ulcer incidents had confusion as a key factor. Only one of these had a diagnosis of delirium by medical staff. The DATEX data for falls identified 16 incidents. 3 of these had 4 AT assessments or mini mental scores completed that were indicative of delirium. These were not escalated for the medical review, whilst 4 others did have a diagnosis of delirium recorded by medical staff. In order to address this, I utilised the Leeds improvement methodology of the PDSA cycle tools. I also contacted Ali Raycraft, who is lead for older adults within SIM, to ask for advice. The initial plan was to identify learning needs. So I hand-delivered a pre-learning questionnaire to 2 pilot wards, J43 and 46. These wards were chosen because they had a high prevalence of falls and pressure ulcers that could be linked to new confusion. The result of these questionnaires identified that 22 out of 23 participants recognised the term delirium, but only one participant recognised the most defining characteristics of delirium, that it's fluctuating, as in it comes and goes. 16 participants felt confident they could recognise delirium, of which 6 understood the need for escalation to medical staff. 8 participants did not feel confident to assess or support patients with delirium and had little to no understanding of the risk factors associated. Of the 16 participants that recognised delirium, only 4 were aware that there were different types of delirium. Hypodelirium was the most under-recognised form. So I did. I developed a 12 PowerPoint learning burst for delirium using pre-existing resources on the Trust intranet, as I wasn't about to reinvent the wheel. This was disseminated to each member of staff on J43 and 46, which is a total of 73 members of staff. An email was sent as high importance with a request for a read receipt for each participant, and an end date was requested for sending back their post-learning questionnaires. To date, I've received 5 post-learning questionnaires back. Although I've only received 5 responses to the learning burst, there's been a demonstrated and wider understanding of the risk factors for delirium and the supportive measures that can be used for people with delirium. There's a greater understanding of the different types and the role delirium plays in patient harms. All 5 participants felt that they could both identify and support patients with delirium now. Understandably, these results will continue to develop as more questionnaires are returned. What went well? The ward members on J43 and 46 were quite actively involved in the pre-learning questionnaire, but I think that's because I actually physically took it to them and wouldn't leave them till they did it, which is probably why I got so many responses. But there was a genuine interest in learning to improve patient safety and reduce harms on the wards. So what I would do differently, I'd ideally deliver that learning burst as a face-to-face, because virtual is better than email. This was sent out via email because of my time constraints, essentially. So I would ideally do that as a face-to-face, because then you can read body language, you can engender discussion, and you can answer any questions that are raised. There were time pressures due to sickness and acuity within the wards, which has probably exacerbated the poor number of post-learning questionnaires returned. And my need to work from home for quite an extended period meant there was a long gap between the pre-learning questionnaire being delivered and the training being provided. And that's the end of my report out. Thank you very much for your time.
Thanks very much, Nancy. Really great. And I think such an important topic that we know we need to continually focus on. So some really good learning there, and some great reflections at the end from you. So thank you very much for that. And wonderfully to time as well. So extra bonus for that. Thank you very much. So can we move on then to the IPC team production board? Sue and Charlie, hi. I think I saw you on the screen just earlier.
Yeah, good afternoon, and thank you for having us along to feedback our quality improvement. So my name is Sue Horvath. I'm one of the senior infection prevention nurses.
And hello, my name is Charlie Lobley. I'm the acting deputy head of nursing for IPC.
So the piece of work that we've done was to look at our safety huddle and production boards and make them work more effectively for the infection prevention team by removing any non-value added waste. So what was the problem? Well, Leeds improvement methodology is well established in our team. We're very lucky that a large number of our team have already done the Lean for Leaders courses, and that we do regularly use Leeds improvement methodology within our team. But this was a piece of work that Charlie and I were doing as part of our intermediate course, and we had a safety huddle in place, and we had a people link board and a production board. They'd been developed several years ago. And whilst these were reviewed regularly, over time, and partly due to the reactive nature for our team during COVID, they had kind of morphed into something that wasn't necessarily functioning as effectively as it might do for the team. And it certainly wasn't helping in terms of being able to visually see what our actual workload was on a daily basis, and when our workloads and the demands on the team were outweighing the capacity. So, as I say, COVID was very reactionary for our team, and a lot of demands were put in place, but we couldn't always recognise when that was kind of like tipping over into meaning that the team weren't able to do some of the other actions and work streams and things that we want to do. Certainly we weren't having that visual source. Also, we felt that the boards that were in place weren't necessarily identifying positive improvements, so we weren't necessarily recognising the achievements that we were actually making, and being able to see when we had achieved things and when work streams were moving forward. And so we felt that was meaning that the staff weren't necessarily getting that kind of morale boost. So just to sort of identify, these were the existing boards that we had, and we just wanted to show this in terms of, as everybody knows, the safety huddle is meant to be around a kind of a quick catch up. What are the safety issues for this day? And as you can see, the safety huddle on the left hand side had kind of morphed into 22 slides, which really wasn't effectively working, and certainly wasn't what the intention would be of a safety huddle. The production board, a lot of work streams had been put on hold because of COVID. So again, this wasn't functioning as we'd want it to. The People Link board, we kind of had a traffic light system, and certainly when I was doing the course, the intermediate course on the Leeds Improving Methodology, there was lots of talk about actually what are the traffic light things showing. So, you know, if something's red, amber, green, what does that mean to the team? And often we were doing this weekly and things weren't really moving. So every week it was red or amber, and that wasn't terribly constructive for the team.
So what we did, we met with the KPO team. Huge thank you, Alex. Alex met with us at very short notice a couple of times just to help us work through it, because we're quite a small team, but you know, we have such a, you know, we cover such a large area, our functions are different, so we just wanted a little bit of guidance and help as to how we're best to approach our new boards. We talked to our team members, asked them what was working for them and what wasn't. We went from the first image of the safety huddle, the 22 slides, it now went down to 2 slides to ensure that the safety huddle was solely about the IP safety needs of the day, and we captured everything that we absolutely needed to do, because as Sue said, a lot of the safety huddle actually was a production board. It sort of morphed into something it wasn't. So we also from the information shared, we decided to set up a more regular production board, so that was our 3 weeks. So we were able to 3 times a week, able to capture all of the actions that we're getting in the safety huddle and more, as we'll be able to show. We utilised the 5S to review the boards, had to make them more simple. And the new boards underwent 2 PDSA cycles, which we'll go on to next. Thank you. Which we use with regular feedback from the team. The first one is through its first PDSA cycle. You'll see on the second one it looks different, so it's that visual thing again. We realised quickly that the first PDSA cycle identified we were focusing more on the nursing elements, when actually the admin elements we weren't capturing, like sending out notifications, etc. So that's incorporated into the second board. And also the blocking out the colour. We don't need to know every day someone's due to do corporate induction on a week on Monday, so we block out so we don't get people asking the questions, repeating the same information. So the outcome is we better understand the demands in our team in a visual and measurable way. It absolutely is a staff morale boost. We're able to be more interactive face to face. It absolutely as well has helped shape the service as we move away from the demands of COVID. 1 to 2 hours have been saved weekly, and although that doesn't seem a lot, that's the equivalent of 4 hand hygiene audits on 4 different wards. So it's a real time saver, and we're confident that will build. And we record 3 times a week if we're in an abnormal normal status. That's still taking a little bit of while to get used to, and what our metrics are for that.
So what's gone well? So it's really engaged the team. We felt that the boards that we were previously using to a certain extent, because we weren't visually identifying where we hadn't got enough staff to achieve the work that was required. The staff could sometimes feel frustrated by that. They were kind of like very bogged down with COVID and the work, and it's like, well, what about everything else? So this has really engaged the team in that they can visually see what needs to be achieved, but it visually shows them what we are achieving, which obviously gives them a huge boost as well. And as we've already identified, it has given back time, although we're doing the production board more regularly because the safety huddle has been hugely reduced. Sometimes it was taking up to 40 minutes, whereas we do the safety huddle every day now, but that only takes 5 minutes. Really, really great.
Really quickly, what we would do differently is we would we could have prepared the team more. I think it was quite a big change, and we did take them on board and they've been part of the process all along, but we recognised that we could have prepared the team better, and that's something that obviously we would do differently. And our next step is to further develop the improvement board. We have paused that slightly whilst we work through with the annual commitments and see how we can incorporate that into our improvement boards. But so it's been a great quality improvement project, and thank you for listening.
Thank you.
Fantastic, really great, really good, and really wonderful to kind of go through the journey that you've been on, and some real threads, really positive threads through all the presentations so far. So I'll just keep us moving then if we can. So we'll come to Philippa next around the documentation around medicines information inquiries. Philippa, thank you.
Yeah, hi. Sorry, I've got a bit of a cold, so hopefully you can hear what I'm saying. So I'm the lead pharmacist for medicines information, and my project was looking at improving the way we document the inquiries we get. So the Medicines Information Service receives about 2,000 medicines related inquiries per year, and we put all these on a software which is called MI Databank. So kind of some examples of what we get are things like interaction queries. So for example, if a consultant wants to start a patient on a new medicine, they would contact us to see if this would interact with any of the current medicines that they're on. Another example we've got is sort of looking at the safety of medication in pregnancy or breastfeeding, and then like recommending alternatives where appropriate. And then we also look at things like herbal supplementation. So for example, patients on chemotherapy and they want to start taking turmeric capsules, we'd look at whether that would interact with their medicines. So yeah, in January this year, we did an external audit with other medicines information centres in the region, and we scored quite low for the level of appropriate documentation. So from that kind of meant that what we were recording wasn't clear who was asking the inquiry, so it wasn't always clear what their job role was. And we got feedback that a lot of the information we copy and pasted from resources without this being streamlined. And a lot of the references we were using weren't referenced correctly. So some of the main challenges we face is that we have a lot of rotational staff, so they come through on a monthly basis, so it's quite difficult to get consistency of training. And then we've also got sort of wider challenges with staff shortages and time pressures to complete the work. So I tried to think about the mental values that we had that would be involved with introducing a new system. So thinking about like the time constraints. And then I sort of thought of ways around that so we could work the training into the current training plan that we have, and that would save time in the long run. And also thinking about sharing the training around the core team. So to prevent us relying on one person to complete the training, we could rotate this, and just trying to improve that consistency of training. And then the other issue we have is around having difficult conversations with people providing feedback. So if we've got a situation where something isn't documented correctly, it's quite difficult. It's quite challenging for staff to provide that negative feedback. Yeah, so I did a process flow chart of how we input inquiries onto MI Databank, and I found that we have lots of steps involved in this, which makes it quite time consuming. And identified waste where we often put in, we add like a new inquiry where I'll explain this on the next page when it's not always required. So the action from this we had was to make the list of inquiries more concise. So this is like a screenshot of the software we use, and this is an example. So like where they've put each person in individually. So for Turner, we had lots and lots of different times where people have put the same person in. We tried to tidy this up, so it was more clear to just select like a doctor at Leeds or a nurse at Leeds instead of inputting each name individually. Yeah, so we did a time metric for this. So I timed how long it took to put this in. So for an individual named entry, it took 58 seconds. And then using the more concise list, it only took 41 seconds. So this would save about 17 seconds per entry, which for 2,000 inquiries a year is about 9.5 hours. So that's like a full day's work we'd saved. And then we also thought about creating some written SOPs to help making the training more standardized. So we made a physical SOP folder which is accessible to staff, and we use this now as part of the induction for the rotational staff that we get, and this is just a way of acting as mistake proofing. Yeah, so I tried to relate the outcomes to some of the improvement method metric categories. So the first one I thought about was the quality, so we're removing the defects because you can no longer free type the names and the details into MI Databank, and we also had a defect in the standardization of the training, so we made some SOPs. And then thinking about the service user satisfaction, so how that's improved the quality of data that we input. Yeah, so we did a re-audit recently after the low regional scores that we had, and we found that our documentation score had improved by 20%, and we had an overall improvement of 6%, so that's good. Yeah, so we had support from the whole team, which went well, and then there's just a couple of quotes there about how it's helped improve it, so it's easier to pull the information for audit purposes, and it's also stopped the creation of multiple users and spelling errors. Yeah, so I think just like reflections, and what I would do differently is try and engage the stakeholders a bit earlier in the project. And my key learning is sort of the different tools for waste reduction, so the 5 S's, and using the different coloured hats for solutions. And then the next steps would be to do another audit in either 6 months or a year, just to see whether this is sort of kept up with what we want. I think that's it.
Okay, thank you. Thanks very much, Philippa, and thank you for struggling through with your terrible cold. I hope you feel well. I hope you've got the weekend to get a bit of downtime and recover from it. It sounds a bit rough, but anyway, thank you for that. And I think great to see something you may not directly be able to see the benefit for the patients and their safety, but of course the knock-on effect of improving that is that. So 4 wonderful presentations, really great, showing various aspects of the method. But so questions, please. We've got some time now to ask any of the team's questions. Hamish, thanks.
Thanks. Yeah, absolutely fantastic presentations. Really enjoyed them. A question for Josh. You mentioned about changes that he was going to make, for the team was going to make to improve staff satisfaction. I wonder if you could tell us a little bit about what they are.
Yeah, so like I mentioned around staff engagement, we have got one being introduced for the entire of Leeds Children's, but we wanted to focus more on the centralised team that works within kind of all the areas within the patient's pathway. So whether we come back together, we're going to introduce these bi-weekly LIM huddles, which is the original team that was at the RPIW, to start kind of exploring what that looks like, and that'll be a representative from each of these teams. So that'll be someone to bring forward kind of the issues that are still needing to be kind of focused on next. So there's still a lot of work. I think we just need to keep that engagement kind of moving forward and making sure that people feel like they're being valued and involved throughout the process. And I think a big part and learning that we've realised from this was we're not celebrating success enough as we should be. And absolutely what we've been able to celebrate so far, we need to kind of keep echoing that and making sure that we're bringing that to the forefront of everything that we do, I think.
Okay, great. Thanks, Hamish. I just wondered, probably for all presenters actually, I mean, perhaps Sue and Charlie, you had a physical production board and you've got quite a small team, but for other colleagues with the sort of digital production board, just how you make sure the team can actually see that, because if you've got quite a wide group of people involved, many of whom don't get a chance to look at their PCs much during the day. How do they get to see some of that great data that you've been producing in your projects? Just wondered, Josh, maybe Nancy, I just wondered what reflections you'd got on that.
So we introduced QR codes to give people a bit of access. So people have their phones on them all the time. So people were joining from their mobiles wherever they were. We made a space for people to attend on the unit where it was very busy, but people could pop in and out of. It's really worked, and we've actually started using it in other meetings as well, which is really good.
Great. Yeah, no, it's really good, Josh. That's a really great use of technology. Nancy, is there any reflections from you? If you're still on?
Yeah, I'm still here. No, there's no reflections really, because I'm doing this as an individual project. I don't have a team, so I'm kind of producing the educational material with resources that are already existing and delivering it myself.
Yep. Okay, thank you. So I guess it'd be an interesting one to hear, maybe if we get a follow-up around how we get some of that information out to the wider team about the great work that you're doing. So look, we've heard lots. What I think is fantastic is the people engagement bit, the work around asking people what they want out of some of this work, the visibility of the improvement that you're all doing, the really tangible benefit, and as much as anything else, the really great use of some of the methods tools, which I think are fantastic. So solving everyday problems with some of the great tools that Leeds Improvement Method gives us is absolutely what we need to be doing collectively. So really grateful to Josh, to Nancy, to Sue and Charlie, and to Philippa for 4 great presentations. And I can't see anyone else wanting to come in, so I think that's the end of Report Out. Thank you very much.